its importance is in what we call personalized therapy. So we really need a lot of understanding the tumor microenvironment itself, the patient factors, trying to predict which so basically what treatment is suitable for what patient, and including the patient genetic factors, because part of our research is looking at HLA, and we did actually found that there is correlation between homozygosity and heterozygosity, and we looked at different supertypes. So combining all those biomarkers there is a move towards that direction. We still lacking the ability to personalize non-small cell lung cancer patient beyond the PD-L1 receptor as predictive marker for response to immunotherapy. So we have not advanced since the FDA approval of PD-L1. There is TMB, which is still it didn't show. There's conflicting data. We are working on HLA, working on pretreatment TCR. There are multiple receptors, multiple biomarkers presented in SITC this year. Very interesting finding, but and even in ESMO, but still none of them has reached or is going probably to reach the clinical scenario, clinical life of a patient or of a doctor yet. Will still take time. We are doing so well in terms of looking at the genetic of the cancer, so the next generation sequencing, analyzing the gene of the cancer and finding targetable mutation. There is a lot of advance in that regard. It's still a lot to be made, still a lot of mutation. We find them and we don't know they're significant. But I guess the work is there. We have as well a few studies here in Australia looking at NGS and treating those patients. But it's the biomarker for response to immunotherapy, especially that we know that not many patients really respond to immunotherapy, but those who respond really respond so well. So it's that area still need a lot of work in order to find the best marker in order to identify patient, and that will lead us to expand to probably guide us to combine immunotherapy with something else, targeted therapy or blah, blah. So in terms of personalization, so it will really be an area of needed from the studies or from the trial, in the trial setup. For every trial setup is to have many biomarkers, all these biomarkers that we are studying them, to be incorporated in that trial. And then, and I'm talking about phase 3 trials rather than just roughly like yes, we randomize patient, but let's do biomarkers on those patients at the same time as an exploratory investigation. And I'm talking about big pharma companies. If they do that, we are going to have a lot of information which we can extrapolate, hopefully, and put those biomarkers together and trying to find out what is the best biomarkers need to be combined to find the best patient and what combination they will benefit from.